Good afternoon, everyone, and welcome back to the Action Collaborative's virtual symposium. Our next session will focus on prevention, treatment, and recovery services. Improving the availability, accessibility, and quality of prevention, treatment, and recovery services for diverse patient populations is integral to combating the opioid epidemic. I am delighted to introduce our participants for this session. The presentation today will be delivered by the Prevention, Treatment, and Recovery Working Group co-leads, Dr. Jay Bhatt, who is an Aspen Health Innovator Fellow and adjunct faculty member at the University of Illinois at Chicago School of Public Health, Dr. Andrey Ostrovsky, who is managing partner at Social Innovation Ventures, and Dr. Alonzo Plough, who is Chief Science Officer at the Robert Wood Johnson Foundation. Joining our co-leads for the session today are our expert panel of reactors, Dr. Stephen Shaw, who is Chief Medical Officer at United Healthcare Community and State, Mr. Aaron Ferguson, who is a Regional Impact Manager with Community Medical Services, and Dr. Michael Schlosser, who is Chief Medical Officer for the HCA National Group and Vice President of Clinical Excellence and Surgical Services for the HCA Clinical Services Group. Their full biographies are available on the event website for you to access. And now I will turn things over to Dr. Plough to kick us off for the session.
You might be on mute, Alonzo.
Thank you, and good morning or afternoon, depending upon your time zone. Thanks for those introductions. Prevention, Treatment, and Recovery Services Work Group. So we have really been focusing on accelerating curation, dissemination of knowledge about best practices, focusing on integrative approaches to prevention, treatment, and recovery services for opioid use disorder, and really how to get that knowledge into scale, practice, and sustain them. So the overall objectives are really to understand, curate, and disseminate what we're learning, these essential elements of this component of the continuum of care, and to highlight particularly the barriers to integrated and effective prevention, treatment, and recovery programs, particularly through a health equity lens, and we'll talk more about that later. Sharing best practices to bring about awareness of these barriers, to implement, evaluate, scale, and sustain approaches, and to really accelerate improvement across the continuum of prevention, treatment, recovery, and services, again, with an attention on populations whose social economic conditions make them vulnerable and high risk around opioid use disorder. Next slide, please. So our working group, and again, I want to express for all of us who are the co-chairs our thanks to a working group that has been working diligently with us over the course of this project. A number of achievements from that group. Published a discussion paper on 9 key barriers and strategies to improve access, use, delivery, and evidence-based treatment to move toward a more functional and equitable treatment system. Published another discussion paper, particularly on the needs of 5 particular high-risk populations and what are these barriers to obtaining treatment and staying in long-term recovery so that we could have more equality in health outcomes. Identify the stigma-related provider and system-level barriers to care. How do we address persisting stigma? And how do we bring this to the level of a national call to action for health systems leaders? And we've submitted that for publication. And then this final bullet here, examine the magnitude, really looked at the social determinants of OUD. Very similar to the kind of social determinants that give you disproportionate mortality and morbidity around COVID-19, and how we can understand how conditions of endemic racism make any healthcare problem more of a crisis around inequity than it should be. We have a paper submitted for publication reviewing that. Next slide, please. Again, more achievements detailed the frameworks of an element of a successful OUD-SUD treatment system. Again, focusing on key strategies to improve and expand capacity, competency, quality of care, and compensation, all necessary. That's been submitted for publication. And then identify the socio-economic mechanisms by which deaths of despair occur, and the policy, institutional, and community level interventions needed to stem those deaths. And I just note that these are not just the deaths of despair that occurred in Appalachia and other areas, but you generalizing to look at that across any population that's been marginalized. Next slide, please. So the lessons from the opioid crisis, integrating social determinants of health into clinical care. Let me just focus on this for this on this slide. We see parallels between the HIV epidemic and the opioid epidemic. The necessity for activism from individuals who have experience with these conditions to really drive approaches that address disparities in access to care and particularly outcomes for the Black population. So we've looked at the need for that kind of engagement and activism. The prevalence of trauma, discrimination, economic inequality, and toxic social environments really reinforce the need for us to collectively support mechanisms to improve these social environmental interventions. Unless we deal with that context, we will be very limited in what we can do on the treatment and clinical side. So this focusing on social determinants in clinical care would lead to a better integration of multidisciplinary teams, social services, better warm handoffs and coordination between clinical systems and non-health sectors. That transdisciplinary cross-sectoral work that would definitely involve the criminal justice as well as other systems would really need to be strengthened and incorporate culturally relevant and lived experience derived strategies. And our national agenda should prioritize identification and dissemination of the many examples around the country of successful community engagement, creative adaptation to community resources, and flexible, locally adaptable funding, really akin to those created by the Ryan White CARE Act long ago for AIDS, HIV. Again, we believe that's a very important finding from the work of our group. With this, let me hand it off to my other co-chair, Andrey.
Thank you very much. Appreciate it, Alonzo. Could we get the next slide, please? Thank you. Our work group has done a significant amount of work over the past really 18 months, but in particular the last 6 months around stigma. There have been pretty substantial work products that have come out, including a wonderful article by some of our colleagues that was published by NAM, and that was Jennifer Atkins, Anna Dott, and Edna Boone. They pulled together a really great manuscript. Additionally, our group reviewed a work product from Shatterproof, which was a comprehensive plan for organizations to address stigma, including for large organizations, corporates, state governments, all the way down to small startups. And some of those themes we capture here. Importantly, the structural stigma against opioid use disorder being rooted in historic separation of addiction treatment and financing from mainstream healthcare, and how there are barriers at the system level present as restrictive requirements for clinicians and patients, gaps in coverage, and lower reimbursement for opioid use disorder treatment. In addition to structural stigma, there's individual level stigma amongst clinicians that manifests as lower empathy, limited patient engagement, substandard disrupted care, denial of care, and limited competency to manage addiction as a disease, including limited use of medications for opioid use disorder. As a clinician myself, at a top tier institution, I see this on a pretty regular basis, and it's systematic. It's a systematic issue. While independent efforts across the health system are underway, a comprehensive evidence-based cross-health system strategy is needed through the following things, which include a commitment to universal use of person-first and recovery-centered language, establishing regular communication on addiction topics with staff and peers, utilizing evidence-based educational efforts and tools to address stigma, engaging and employing people with lived experience and trained, licensed, and skilled addiction specialists. That latter point, the Opioid Collaborative took to heart and is walking the talk in that we created our own lived experience work group, and we're very grateful for those individuals who are informing every work product that's coming out of this body of work. Additionally, expanding equitable access to MOUD and prevention, treatment, and recovery services through enhanced provider training, integrated care, and inclusive reimbursement policies and incentives. So a lot of really great work on stigma, and it's a matter of putting those principles to actual work within our collective organizations that we're leading. Next slide, please. So in addition to stigma, there was a pretty large work product in thinking through the future directions of the opioid use disorder treatment system. A big impetus for this body of work was thinking through how different jurisdictions could use some of the opioid lawsuit settlement dollars, and that really inspired the conversation here. Interestingly, this very work product, which right now is in, I believe, final review within NAM, could very well be used to inform some of the transitioning policies that are emerging. And obviously, we're not a policy setting body, but I do want to draw attention that this work product has some really fantastic points, and not just because I was a co-author, it's because the other co-authors were really fantastic. So some of the key insights here. So we worked on a framework to create a more robust and equitable treatment system, which should address key barriers and opportunities across capacity, competency, consistency, and compensation to improve the treatment of OUD and other substance use disorders. And that paradigm of the 4 C's, we really have to give credit to Dr. Corey Waller from HMA. It's such an easily memorable construct, and it's incredibly comprehensive. Additionally, the addiction care system was not built upon the understanding of addiction as a chronic medical condition, which manifests across challenges in funding and quality requirements. That's something that folks like Nora Volkow have repeatedly been a champion to reinforce, that in fact, this is a chronic brain disease, and the scientific literature supports that. Building capacity, competency, and consistency requires leadership across the compensation domain. Payment, ultimately, so many of these changes come down to payment, and that's instrumental. And some of the priorities for ensuring accountability and transparency in addiction treatment include the following: identifying and ensuring availability of the entire continuum of care as defined by state and national guidelines and capacity recommendations, ensuring qualified providers can bill for treatment of addiction and actually get paid. Next slide, please. Shift funding incentives to programs that meet baseline quality standards and demonstrate positive outcomes. I used to run a series of opioid treatment programs, and trying to be compared to other opioid treatment programs where there weren't really well-established quality standards was incredibly difficult for us to be recognized for the good work we were doing. That's changing, by the way. There are some really promising initiatives along those lines, including tools like Atlas that, again, the nonprofit Shatterproof has pulled together, and some other folks as well. Eliminating barriers to information exchange by incentivizing EHR data capture and integration of claims data for individuals. On that piece, there are some productive changes around interoperability rules, and now we just need to empower innovation to happen there. Standardizing care delivery levels and ensuring compliance with requirements. Standardizing levels of care by licensing and contracting treatment programs by national criteria. Requiring oversight of programs through independent evaluation of clinical care quality, including things like state on-site inspections and CARF's ASAM LOC certification. That's a really interesting partnership there between CARF and ASAM. Develop enforcement mechanisms for current parity laws and regulations. MHPEA has been around for some time. It has not been particularly well enforced. Some states like California are leading the charge, and that is just starting to happen. We really need to accelerate that. Also, I'm very excited for our reactor panel on their thoughts there. Finally, last but not least, find and eliminate instances of fraud and predatory practices that have arisen as a result of poor enforcement of quality standards. Next slide, please. And I believe I'm handing off to Jay. Thank you.
Great, thanks, Andrey. And I've just appreciated the opportunity to work with you and Alonzo in this initiative. And just we've had a fantastic team that I know has made me a better professional and human. So I'm grateful to them, and Taisha and your team at NAM. And the work that Alonzo and Andrey spoke of has informed pretty robust discussions in our group about how we build on the effort for future direction. So really translation and bringing the papers and tools that we've worked on to life. And I'll just tell you, just yesterday, I saw a patient in my Southside Chicago Community Health Center clinic, a 23-year-old male in recovery, living with his family, working multiple jobs, now sober for 2 years. But what I learned about his difficult journey, that it had fits and starts, and that it started with opioids being used for back pain after a work injury. And he talked to me about how an interdisciplinary team eventually helped him move forward, make change and stay on course. But it took real intention and a system to bring that team together. He now works to help others with addiction and that have emerged as an issue for these individuals through the pandemic. The system, or rather the network of caregivers, seemed to work well, but also fell short on prevention, not only up front, but through the process, and in addition to other important issues. So he had been donating blood to be helpful, but it wasn't until several rounds through that he had discovered to have hepatitis C. And so that's a big part of the conversation we had. So this piece about, where we talk about building on the consensus study of the medications for opioid use disorder to save lives, to prioritize the adoption of strategies that promote the continuum of care for opioid use disorder. It's critically important through prevention, treatment, recovery, and associated conditions. And so the working group moving forward will utilize its membership and network organizations and the stakeholders they work with to conduct dissemination and implementation activities that accelerate widespread use of prevention strategies. And we've spent a lot of time on this issue to try to go upstream, and that integrate with thinking about social need, social determinants of health, and health equity, or systemic structural issues, which aren't all the same thing, but with overlap. So the language matters because the interventions and what we might do changes, and how do you get the most impact? Because you're either talking about social need, a social determinant, or a systemic structural issue. The other thing I would say is that the anti-stigma practices work that Andrey spoke of has been so critically important. And the way we think about that is, how do we elevate the issue of anti-stigma, empower and equip the health system with capabilities and tools to do that? And we mentioned the great work that led to the paper that was produced. I think this will be a good foundation for continued work and alignment to move forward issues of health equity that we heard about this morning and that we've heard through this conversation. And third, this commitments from payers and hospital systems, who are critical stakeholders, to advance pilots, leading practices and strategies to enhance the 4 Cs across the treatment system is important. And we've learned so much over the last 10 years around demonstration projects through CMMI and other efforts, and even local regional collaborations about how we might do this work and how do we create an evaluation that allows us to learn from it. And the pandemic has spurred innovation opportunities and exposed more members of the payer and health system community about how to do innovation and be comfortable with it. That it's going to take policy levers, system levers, and environmental levers to make a difference. Next slide, please. So the other proposed focus areas and priorities, there was a lot of discussion on Alonzo reference around social justice, nonprofits, community organizers, and health delivery systems to elevate and disseminate evidence-based resources around social needs, social determinants, and health equity, particularly around high-risk populations. And now, we're learning more and more every day about how to do this work better, and that it's got to be measured, it's got to be evaluated, and we got to learn from that to then move forward. On the stigma issue, again, I think about this sort of framework of elevate, empower, and equip, and expanding adoption of anti-stigma practices across the system, and actually, measuring it and creating on-ramps for folks where they're comfortable. So you might be kind of at level 1 or level 2 or level 3, and how do you get to the next step? And so that starts with commitment from Action Collaborative members and network organizations to adopt and use anti-stigma language, provide the guidance and evidence-based content, and then elevating and disseminating the current evidence base of anti-stigma practices, but also lifting up stories of where we've been able to get adoption, where it's worked, and how we've also learned from those positive deviance approaches of how to do it effectively. And I think sharing those stories across the network and in the field, but also then learning from those places where it may not be working well and why. And you think of a number of things from roundtables to have this conversation with your leaders. An organization could put forth an anti-stigma statement, acknowledgement of stigma, and connect it to their mission, vision, and values. And then developing a series of listening sessions and a mentoring pathway, and expand access to these resources and make it easy to access and use. And again, the voice of lived experience that we feel has been so instrumental to our work, bringing that forward. Next slide, please. So earlier, Dr. Odom referenced the opportunity for health system experiments. I think the National Academies plays a powerful convening role to share leading practices, the next practice, and we could put that potentially on a dynamic map that allows stakeholders to see what is possible, what can scale, and demonstrate evidence that works. And I think this idea of a framework, the 4 C's or others, is really important in our age-friendly health systems work. When I was at the American Hospital Association with IHI and the John A. Hartford Foundation, we used the 4 M's: mentation, mobility, medication management, and what matters to you, as a reliable evidence-based model, and went from 26 pilot sites to greater than 500 over 3 years. And so that's because it was made easy by helping people understand what they're trying to do. How do you play your role? How do you operationalize? The other group that I think about is CDFIs in this environment, community development financial institutions, who convene partners and provide capital investment in low-income communities. And I would just end by saying this issue of benchmarks and measuring is important. You can't improve what you don't measure. And so that end, we said 20% of health systems age-friendly by 2020. This idea of aims creates systems, and systems create results. And so with that, I'd like to move on to our reactors, who we're so grateful to have. With that, I want to, before I move to reactors, see if Andrey or Alonzo, you want to add anything else I missed?
Well put. Thanks, Jay.
Okay, so let me turn it over to Dr. Stephen Cha. It's nice to see you, and thanks for being here.
Nice to see you too, Jay. Yeah, and thank you so much for inviting me to be part of this. Just fantastic work, really timely work, really important work in terms of thinking through where we are. It happens to be coming at a time in the context of COVID when we're all really thinking about this, but we've been thinking, a lot of us have been thinking about this for a long time. So appreciate the work of the panel here. I'm struck by the scope of the report and the scope of the recommendations. And it strikes me that it sort of falls into, at least in my mind, 3 buckets. There's first a lot of hard stuff to do when we think about social determinants of health, when we think about connecting systems between justice and housing and social determinants of health. A ton that we need to continue to unpack there. We could talk for hours just on that alone. We at United have now over 500 million invested in housing, just as for instance. We're committed to really unpacking how the SDOH pieces need to interact with healthcare in a more productive way. And there's no better use case for that than the opioid crisis. So there's a lot that we need to do and continue to unpack. I'm also struck, though, that there are 2 other buckets of work that we should think about, and that in a sentence, as a payer, as someone who's responsible for the clinical care of 6 million Medicaid members, I think quite simply, we need to pay less for bad stuff and pay more for good stuff, right? Just to be very direct about it. And when we're thinking about this, I know the morning talked about opioid prescribing practices. I think that's certainly part of it. But we also have, on the treatment side, a lot of providers in our network that don't include the full spectrum of care. Lots of providers that don't even include MAT in their treatment protocols. We got to do better than this. I so appreciate the work by CARF and ASAM and the work with Shatterproof and Atlas to really try and standardize and categorize and help us as a payer identify how to make some of those distinctions. But we need to build off those efforts and move quickly towards transforming the network to say, we shouldn't accept where we are as a nation. It's not good enough in terms of where we are in accepting that. We need to go faster. We would never pay a hospital that doesn't prescribe beta blockers after an MI, right? And so we need to think about how we're moving that along. And then the third bucket for me is we need to pay more for good treatment. We need to really think about how are we incenting and supporting the transformation of the treatment infrastructure here. And I'm also hopeful those 2 pieces will help really change the stigma conversation and interact with the hard stuff and interact and support and synergize with our efforts to really address and create human beings out of the people that we're trying to treat, which so often is a challenge in this movement. We have launched, for instance, micro incentives for MAT, meaning that for lots of providers that we have this deal with, if you prescribe more MAT, we will pay you more, quite simply. We're evolving those to hopefully evolve into an episode bundle of care, but we need to think about that. We've removed prior authorization for MAT in every market that we can, but we have a lot of states that still mandate to us that we have to prior auth a lot of these treatments. We need those policies to go away as well. So when we think about how we're approaching this, there's so much more we can do to support that whole infrastructure and to think about peer support and to think about the community partnerships that enable the appropriate use of MAT, because we know it's not just the medication alone, but we've seen great models for that, and we can do more to fund, finance, and expand some of those efforts. So I want to be respectful of time and my other panel members, to keep it to 5 minutes. But just in a nutshell, I think the imperative and the urgency is the key for us. We've been sitting on a lot of this knowledge base in terms of what works and what doesn't for too long now. And I really appreciate the effort of the Academy to really crystallize some of the specific directions we have to go in today, yesterday, the year before, to really address what that imperative and urgency really looks like. And our strategy is really to focus on early wins around, again, small projects around MAT to build and change the culture, to change those baseline expectations, to really create an overall environment to take on the hard and continue to work on the hard together.
Thank you, Dr. Cha. Those wonderful comments, and appreciate it so much. And I think this notion of, let's make it easier to do the healthy thing and incentivize the continuum of care, and MAT being an important part of that continuum of care. So I'll go to Aaron Ferguson now. Really appreciate you being with us. Thanks so much.
Yes, thank you so much, Dr. Cha, and thank you so much to everybody with the Academy and for all the work that you guys are doing. Really enjoyed reading the 2 papers that were published there. And I think this is an important topic to be discussing in general. I work for a national provider of medication-assisted treatment. We opened the first 24-hour methadone or buprenorphine clinic in the country 3 years ago and have treated over 11,000 patients at that location since its opening. We have 49 clinics across the country in 9 states and are deeply integrated in the criminal justice system in every instance that we can. My job has to do a lot with mitigating discrimination against our clients in healthcare settings, mitigating discrimination against them in the court settings, and mitigating discrimination against them in their just everyday settings. And so this is a topic that's incredibly salient to me. I've been asked if we were to focus on one thing from what was just presented, what that would be. And I am inclined to apply my focus towards stigma. I view this as kind of a tricky topic because on the one hand, we have a problem of stigma from the general public, but then we also have a problem of stigma from people that are supposed to be educated about this issue. And so it's coming from both within and from without. And what this leads me to conclude is that stigma is not something that has been intentionally educated, and that we need to view it as something that is implicit in the same way that racial bias is implicit. So realizing that it's something that we all have, even people who use drugs have stigma against themselves that is internalized. And so we need to recognize that there's deep conditioning regarding people who use drugs. Both in politics and in the media, we have all been exposed to a systematic conditioning to view people who use drugs as less human, less moral, and that's not going to go away just because we say it should. We have this stubborn notion of a drug-free America that's simply naive. And we need to have open and honest conversations about people's moralistic judgments about substance use. So any stigma campaign that wants to really make a difference needs to follow some of these steps. It needs to openly address people's individual moralistic judgments. It also needs to take a top-down approach from a regulatory standpoint. So long as drug use is criminalized, people are going to tend to view it as deviant. So we really need to push back against the systemic denial of citizenship for people who use drugs. A great way to do this is just to use real-world examples from people who use drugs non-problematically, or to encourage an open and honest utilitarian discussion about the actual rather than perceived harms of substance use. Much of what we're calling a disorder is the result of people procuring a substance that's illegal and all of the things that come along with that. So at the end of the day, what we need to do is to stigmatize stigma. We need to turn stigma upon itself. And so that a person would be worried and afraid of acting in a discriminatory manner against a person who uses drugs or is in medication-assisted treatment for fear of being stigmatized themselves. And there are ways we can do that from the bottom up and from the top down. I've also asked how you can make priorities more actionable. So what are the types of strategies that may be needed? In this avenue, I would recommend strongly supporting the deregulation of methadone and buprenorphine. COVID-19 is an excellent example of sort of the double standard that's being applied to these medications. You know, the fact that people had to show up in person to receive methadone in the middle of a pandemic, whereas buprenorphine was allowed to be conducted via telehealth, that really speaks to stigma's continued hold on both the regulatory system and on treatment providers as a whole. So we really need to think the double standard that we're applying. We really need to rethink about the double standard that we're applying to these medications and the regulatory practices. Another really important step is that I think that healthcare providers need to be trained on the principles of harm reduction. You know, are healthcare providers aware of what harm reduction is? Do they know what it constitutes? And there are organizations in the community that can really help out with that if we can build partnerships. Also, I think it's important for there to be real world consequences for people who are discriminatory against people who use drugs. You know, as it stands, if you're clearly discriminating against somebody for their gender or for their race, you're going to have some consequences, but there's no such thing in the realm of people who use drugs. So we need to have some, you know, there need to be some actual disincentives for acting in a stigmatizing manner towards people who take substances. And then finally, I would strongly support treatment for associated conditions, and that was mentioned earlier on in the presentation. So important to treat people with hepatitis C. You're not going to find as many people who are hepatitis C positive as you would in a clinic, you know, receiving treatments for medications for opioid use disorder. And that's an opportunity. It's really an ethical imperative to address people who are struggling with those conditions and engage them at the level of their physical health. Finally, I've been asked, you know, what some of the potential facilitators or barriers are to implementing some of the proposed actions. First and foremost, you know, we have a war on drugs, and so long as something is illegal, people are not going to want to report it. The real reason why people are dying is because they feel the need to hide their use, and for good reasons. So the real question here is, how can we start a conversation that's open and honest about what people are actually doing, and in a way that people aren't going to be worried about being punished for it? We have a treatment system that is itself almost a form of punishment in many instances. So we really need to rethink the way treatment is being delivered. You know, this belief that force is the best medicine against people whose brains are hijacked and simply can't think for themselves and need to be forced into sobriety is just not helpful. And, you know, the way we can do that is reframe this through a harm reduction perspective, employ peer support specialists, you know, build bridges with syringe service programs. People who go to syringe service programs are 5 times more likely to get into treatment, 3 times more likely to quit using, you know, so we have these agencies out there in the community that we can build partnerships with in a positive way. I just want to give a really quick quote before I hop off here and allow the next panel member to speak. It's a quote from Cassandra Frederique with the Drug Policy Alliance. She says, There's an idea that policing is a noun when it is actually a verb. There are multiple people policing our communities in different ways, but they don't have badges. So I think it's important when we're talking about stigma for us to think about the ways that we're policing and shift our focus from one of policing to one of trying to help. And thanks so much for having me here to speak on this topic. Really appreciate the work that the Academy is doing here. Thanks so much.
Thank you, Aaron. Appreciate your comment on being intentional and how we can strategize around the stigma issue and being partners with our patients in these efforts. So appreciate that. And now I'd like to go to Dr. Michael Schlosser. Thank you for your contribution and efforts, and look forward to your comments.
Great, thank you. Appreciate you having me on today, and thanks to the National Academy of Medicine for hosting this event today and having me on as a reactor. I also have the privilege of participating in one of the work streams as well, and so I've been just really thrilled to be part of this effort and proud of the work that has been accomplished to this point. And really have to say this has been a terrific symposium so far today, just great dialogue and great comments and conversations. So kudos to the team for putting this all together. This is a really interesting topic, and I have to say I participate on the guidelines group around pain management, and between trying to figure out how to prescribe less opioids and address pain management and figure out how to do a better job around treatment and recovery, I'll take pain management all day long. This is a far harder challenge to take on. So great work by the group and what you've accomplished. And I really wanted to call out this framework, the capacity, competency, consistency, and compensation. I think that's a really great way to think about the issues that we need to tackle across the treatment and recovery spectrum. So a few topics that I wanted to kind of focus in on a little more deeply in my comments, and I'll kind of echo some of the things that Aaron said around, I think, stigma being one of the most important pieces of this entire space. As I was reading through some of the work that you all did and listening to the presentations again today, it really jumped out to me how many parallels there are between the stigma around these patients who have opioid use disorder and the work that my organization is doing right now around racial and ethnic disparities. Obviously an incredibly hot topic as well this year, and we've put a lot of really intentional work around addressing those issues. And a lot of it is focused on our leaders within that part of the organization doing some very detailed and intentional education across our entire company. And, you know, we have 275,000 employees, so that's a lot of people to educate. But really, it feels very different. I mean, I've been in many, educational opportunities and seminars and classes on racial disparity in the past, and it's, part of a lot of education programs, but it feels very different this time where we're really focusing in on the fact that whether you realize it or not, you probably are part of this problem, and you need to really look inward and figure out what it is that you're doing that's creating this problem, this concept of microaggressions and the language that we use. And as I was thinking about this concept of stigma we've talked about today, it just parallels and resonates that I think the way we as healthcare providers manage patients with opioid use disorder in our emergency rooms, in our hospitals, in our clinics, it really is the same issue around the way our language and our approach to them creates barriers. It teaches the people around us to behave differently and act towards those patients differently. And it reinforces this whole idea that they're, a lesser patient, or they have a lesser healthcare problem than all of the rest of the standard kind of or mainstream healthcare, as I think you all refer to it. And I don't see a great pathway forward for us as a healthcare provider, speaking for me and my organization, unless we can fix that. And similar to what we're doing around racial disparity, unless we can change that behavior and really get people to understand what it is that they're doing in their day-to-day when they interact with these patients or interact with their peers, and the effect that that's having on these patients' ability to get the treatment they need, I just don't see how we're going to make really positive change. And so I really echo the comments that I think stigma is something that we're going to have to tackle head on. I would encourage us to think about the approaches that are being taken to address racial disparity and think, how can we piggyback off that or maybe mirror some of that education and training that's going on. And it's going to have to be widespread. And fortunately, as the person providing the health system perspective, I maybe don't have to focus as much on how you're going to have to train 330 million Americans to think differently. I can maybe take the more narrow view of I just need to train my 275,000 employees to think differently about this patient population. But I think we're going to have to do that, and it's going to have to be very intentional and very thorough if we're going to be able to get over that barrier. And then the next piece that I would focus on is competency. And I had a quote that jumped to my mind as I was thinking about actually all of the presentations today. And it is that the world is perfectly designed to get the results that we're currently getting. And that comes from Joseph Grenny, who writes a lot about influence. But I think that our world right now is perfectly designed to get the outcome that we're getting with opioid use disorder patients. And so we're going to need some significant structural change. And the one that my mind immediately hones in on is competency. And that is, there's so little competency throughout our entire health system. And again, I'm speaking about my provider system around how to treat and how to manage these patients, that it creates, I think, a sense of helplessness, which feeds into the way that we manage these patients when they come through our health system. And so I think about my emergency rooms and how well trained and how competent are all the people in an emergency room to manage the various aspects of opioid use disorder. I think when you change that level of competency, when you give people tools to be successful in treating these patients, their attitude and approach to them changes dramatically. And I'll use an example of an emergency room we have in South Florida in Palm Beach County, which is just a very difficult environment, a lot of opioid use disorder, just a high population of opioid users. And they stood up a clinic adjacent to the emergency room where they could begin medication-assisted treatment kind of immediately. So patients would come in with overdose or other acute intoxication, and after stabilizing them medically, they could be immediately transferred into this unit and be started on therapy and then transition to other outpatient resources once the therapy had begun. And it completely changed the entire approach of that emergency room to this population, to the point where they now want to be a receiving center for all of EMS opioid overdoses or drug overdoses in general for the community, because they feel empowered and they have the ability to make change in these patients' lives. And so they no longer feel helpless, like I'm just going to give them Narcan, they're going to leave, they're going to come right back. They feel like they can really do something and have positive change. And it's really changed everyone's thoughts and approach within that ER, which I think is an example of how increasing competency can have an amazing impact on the outcome. And then the last one I'll touch on is compensation. And while I completely agree with everything that's been said, that we've got to figure out how to make this more attractive from a compensation standpoint if we're going to get healthcare providers on board, I would say that my health system is constantly looking at opportunities to stand up addiction treatment clinics, and that we have interest even under our current compensation systems in doing this, but we need more support and help and direction. And so I like the idea of more accreditation and oversight, and that may sound weird. I'm usually not asking for more accrediting bodies to come into my hospitals, but I think that one very positive aspect of those accreditation approaches is it provides frameworks so that we know what good looks like. So if we want to get further into this space and we want to stand up more centers where we can treat these patients, we would have a framework and a way to be assured through an accreditation process that we're doing everything that we should be doing, that we're providing high value care, that we're touching all the bases that we should be touching. I think about, how helpful it is to have an accreditation model around our acute stroke program so that we make sure we have all the right pieces in place to treat those patients. I think we would welcome the same around providing good treatment for patients with addiction or opioid use disorder. And then let me make one final comment that, again, I think goes back to some of the work we're doing around disparity. We realized that if we were going to address our issues with racial disparity, we were going to have to get better data. We were going to have to start segmenting our data and studying our data to be make it more visible about where we might be treating patients different based on their race and ethnicity. Otherwise, we were going to never know what we don't know, and we can't manage what we can't measure. And I think we need to do the same thing around how we treat patients with opioid use disorder or other drug addiction problems. And I think we need much better data to know where are we doing a good job and where are we not doing a good job. So that I think it was Aaron who mentioned, so that we can hold people accountable when they're not doing what they should be doing for those patients when they come through our health system. We need to be able to measure that and hold those providers accountable if we're really going to drive change. And then I'll end with this. HCA as a healthcare system, we love pilots. And so I'll just offer up that if there are innovative models to treatment that anyone involved with this national collaboration wants to propose, we'd love to be involved and think about how our health system, our footprint might be a great way to learn more and to test out some innovative ideas. So thank you again for the opportunity to make comments, and I'll turn it back over to our presenters.
Thank you, Dr. Schlosser. You were fantastic in helping us think about, how do we help organizations integrate what they're already doing to help advance the work around opioid use disorder and addiction. And so I think some great thoughts and examples there. So I know we have a little bit of time for discussion, and I'll ask Aisha to keep us honest here on time, but turn it over to Andrey. And I know that we want to moderate a short discussion here.
For sure. And let me just check with Aisha. How much time do we have?
We are technically at the end of this session, but we do have a break that's following. So as people can stay on, we can use that for discussion.
Okay, sounds good.
So we have 10 minutes, yeah.
Got it. Maybe we'll use the next 5 minutes for that. So one thing I'm observing is I love Aaron's comments because Aaron, you get right to the point. And I've run methadone clinics before. I've been in policy before, and unfortunately, I've had family members that overdosed and died. So I want to kind of cut right to the chase of what I believe is essential for real change to happen, and that is how can we design the system such that payers, providers can profit off of doing the right thing in terms of prevention and treatment. And Steve alluded to aligning incentives with outcomes, but I'd love to learn about and celebrate who are folks that are actually doing that. What are the concrete examples, and how are we getting beyond, this is a great conversation, but talking and actually committing real capital to restructuring either medical policy as a payer, restructuring care models as a provider. Anyone familiar with examples of how that is actually being done in the field?
So maybe I'll just throw out one piece of data to share, Andrey, which is that there was, and I don't know if on this call, but some great data coming out of the Vermont hub and spoke model. So just to give you about, I'm rounding off numbers, say about $12,000 a year that's the cost of an average member with OUD. If you put them on MAT, even subtracting the cost of Suboxone, which is $200 a month or so, it's $11,500 a year, right? And so the point is there's a delta there. Now it's not much, in terms of how we think about projects that generate money, but we're saving lives at less money, right? And so the problem is sort of a wrong pocket problem. So let's say I, as United, stand up a great model there. Well, if the risk adjustment isn't right, I may only get paid, say, $3,000. And even if I'm saving the system $500, we may be losing $8,000. So that was a complex way of doing the math. But just to say, we're going there anyways. I think we're saying we think the states will catch up with us. But there's sort of this, all of us sort of inching towards the right incentive framework. The math is there. We just got to keep moving and evolving and inching towards the right model.
That's great, Stephen. And one note on that, there's a body of work right now to try to ideate around how to incorporate some social risk factors into risk adjustment, which I think could be really interesting. And as an analog to that, can risk adjustment for people with opioid use disorder, which almost inevitably will have a lot of upstream issues to deal with at some point in their journey to recovery, can payers actually get a higher premium, and in turn can providers benefit from some of that passed through premium for taking on risk for folks with opioid use disorder. So stay tuned, more to come on that. Thanks for that, Steve. Any comments from Michael or Aaron in that regard?
I'll just say that there's a definite, there's an upward benefit of providing good services, which is that word gets out among people who are struggling that your services are not going to discriminate against them. And when people find out that they can go in somewhere when they're in crisis and they're going to be treated with compassion and respect and dignity, they're going to come back. When people are offered access to medication-assisted treatment in a criminal justice setting, when they're in a crisis in their life, they're going to come back. And word on the street is paramount. You know, the stigma around mental health services is itself embedded within the people who need care the most. And that is a problem that has to be tackled. We can do all we can to provide financial incentives from within the system. But unless we make treatment attractive and less punitive and something that people really want, we're going to fail to really reach the scope that we could otherwise. And so really seeing and asking the question, what would I want a family member to experience if they were struggling with this? What would I want my sister, my brother, my daughter, my grandparent, what would I want them to experience walking in the door with these problems? It seems simple, but it's often counterintuitive, and it really is something that's going to elevate the standard of care.
That's great. Thanks a lot, Aaron. It sounds like an opportunity for market share gaining if systems were to follow some of these principles we discussed, and they would attract more patients, more beneficiaries, more members, which could be a very appealing in many settings.
That's one comment I wanted to make is that I think, and I'm going back to kind of the disparity conversation, but I think that if you have means, there's a lot of good options for treatment available to you right now, right? I mean, I think that when we say that there's a lack of access here, we see a lot of cash paying centers popping up all over the place for addiction recovery. Now, I haven't audited the quality of those programs and the services they're providing, but I think that there's definitely plenty of options available to you if you have means. And so how do we address the fact that there's that massive disparity in the system and that there's providers who are incentivized to only provide treatment to those who have cash to pay? There's lots of other aspects of the health system where we kind of don't allow that behavior of I'm going to discriminate based on what type of insurance you have or how you're able to pay for a service, especially something as critical as this. So I think this is something worth putting out there on the table.
That's a really great point. I know we're now over time. Maybe any final thoughts from Jay or Alonzo before we wrap up?
A great panel. That last comment shows how stigma can become incorporated in payment, and you have to address the stigma to address its many manifestations, systemic manifestations. Excellent panel. Thank you all.
I would agree with Alonzo's comments. Thank you all for your comments and reaction. I think there are just some good comments in the chat, related both to the hub and spoke model, to integration of interdisciplinary efforts, and then the role of a centralized addiction medicine program along with decentralized components of a health system. So I think I really appreciate the comments there. So, and thanks to Nam.
Awesome. Thanks, everyone. Maybe a note for our internal meeting tomorrow. I think it'd be amazing to internally account ourselves for how many actions are actually taken up based on the great ideas that have been discussed here. I think even if we get a handful actually implemented, then we're winning. And I hope we do that, because otherwise it's just another webinar. Thanks, everyone. Really appreciate it.
Thank you all. Really appreciate your time and for making this a truly engaging session. We We'll be moving on to our final session for the day. So we'll get started in just about another minute. And we'll be talking about research data and metrics needs. So we'll be back with you shortly to begin that session.